model that our Hill friends here have instituted in our ACO in San Francisco with UCSF and Blue Shield. Then I'm going to turn it over to Nancy and Dennis, who have been colleagues of mine for my long storied career in pharmacy, and they're going to talk about the health plan pharmacist and where the health plans are moving with respect to pharmacy in somewhat non-traditional roles. And then probably most near and dear to my heart is the idea that if we do not get practice into the community pharmacies, we are not going to achieve the mission of caring for all the people that need to be cared for. So I've got Risa and Stan from our Safeway Albertsons community pharmacies to come up and talk about a very innovative model that they implemented nationwide, and also about the possibilities and what's going on in the community pharmacy. So I don't think anybody would necessarily in this room dare disagree with one of the most evidence-based decisions to improve health systems is to maximize the expertise and scope of the pharmacist. And that came out really with the 2011 report of the Surgeon General, which cited 55 outcome studies looking at multiple settings for the clinical pharmacist, that looked at how the pharmacist was effective in improving care in both the ambulatory and the hospital-based clinics. And I think we've done a really tremendous job of looking at how the hospital pharmacist benefits the patient, and now we've moved to how the ambulatory pharmacist improves the care of the patient. But we haven't really touched on how we get into communities with patients. And I'm hoping that we can get to a bit of that today. But despite that, the Surgeon General's report said, regardless of setting or disease state, the addition of a clinical pharmacist to the care of the patient results in improved care, and thank goodness, there's no evidence of harm. I think also when we look at it, we have to look at the outcomes. And when we look at outcomes, I think any of you who are working in patient care today will realize that unless we promote patient engagement and patient activation, we will not win this battle. We cannot just tell people what to do. And I think that what this study and what this report highlighted was the fact of how pharmacists are able to promote patient involvement. And obviously, cost effectiveness, cost efficiency are huge factors in the expansion of healthcare. And so all of these things, as well as reducing the demands on already overstrapped healthcare providers and an overstrapped healthcare system, all is a perfect setup for the pharmacist on the care team. Not only did the Surgeon General's report come out with this, but HRSA, and my fellow pharmacist and champion down in LA, Steve Chen, has been really involved with HRSA and their work. But HRSA really also strongly supports the role of the pharmacist in the provision of services to patients. And in particular, those patients with multiple chronic conditions and in an interprofessional manner. So all of this is becoming a theme. I think also when we start looking at where the pharmacist needs to be involved, it needs to be right at the grassroots level. It needs to be as a teamlet. When Tom Bodenheimer came around and spoke to us, he talked about teamlets of care. And pharmacists cannot provide care in isolation. The pharmacist, if they're going to be effective, has to work in this team-based system, whether it's virtual or not. Then if you look at the Patient-Centered Primary Care Collaborative, which has over 700 collaborators nationwide, you'll see that they've looked at the ROI of med management services that are provided by a pharmacist and show that the ROI is as high as 12 to 1, with an average of 3 to 1 to 5 to 1. So those are really significant ROIs, which show that we really should be investing in the pharmacist on the care team. So let's take a look at the national evidence for the pharmacist's involvement directly in hypertension. I have to tell you, I don't think there's another disease state that, or another condition that has quite as much evidence as hypertension. It spans Washington with the Everett Clinic, Group Health, the Iowa Project, the Asheville Project in North Carolina, 2 Minnesota projects, And if you look at it over and over again, you see improvements in blood pressure goals when the pharmacist is involved in the group practice. And that's always compared with standard of care. Iowa Project, 63.9, reached their blood pressure goals compared to 30% in a control group. Asheville looked at more than just hypertension. They looked at diabetes as well. And when you look at this, you see a 24, almost 25% increase in diabetes goals attained and a 20% improvement in blood pressure. And Asheville was quite a long time ago. It was really the first study that came out nationally that hit the press in not just pharmacy journals. Minnesota's been a pioneer in many of its medical group practices, partially because Linda Strand, the inventor of pharmaceutical care, is from the University of Minnesota and has studied pharmaceutical care in that environment. But the Minnesota project showed 71% of patients met HEDIS goals in the pharmacist intervention group versus 59% for usual care in the area of hypertension. Group health, again in Washington. Again, pharmacists are co-managing patients. Pharmacists are taking on panels of close to 10,000 chronic disease patients, and they're working typically in a ratio of 1 pharmacist to 5 physicians to help manage their patients with chronic diseases. I'd like to focus on one of the more recent studies out of Minnesota with Health Partners that looks at home blood pressure telemonitoring and pharmacist management, because I think it represents exactly what we're talking about. We have to figure out how to get to patients where patients live. Patients live in their home. When blood pressure, when we look at blood pressure control, we know that we do much better if we activate patients to get us what their blood pressures are throughout the activities of their day. We also know that patients spend, hopefully, this much time in a hospital and maybe this much time in a clinic. So if we can't start getting to patients where they live and in the communities that they live, we're not going to be successful. So we've got to figure out new ways to do this. So if you look at these telemonitoring interventions and disease management in hypertension by the pharmacist. So patients got an in-person visit initially with the pharmacist. They were given telemonitoring equipment, and then the pharmacist would check in with them. And this study was really remarkable because it looked at patients at 6 months, 12 months, and then the intervention stopped with the pharmacist. And they looked at the patients 6 months after they stopped the pharmacist's intervention, because many interventions we know activate the patient. When you're right on top of the patient, everything goes well, and then you leave things alone and they kind of begin to fall back to baseline. This is one of the first studies that looked at 6 months post-intervention and found that not only were the results sustained, but they were improved. That patients actually had better results at that 6 month post-intervention point. So just to highlight, I don't know if I have a pointer here. I think I do. Do I? Okay. So if you look at the telemonitoring and you look at these blood pressures and you look at them compared to the reduction from baseline in usual care at 6 months, 12 months, and 18 months, you're seeing reductions of 21% to 22% at 6, 12, and 18 months in the telemonitoring, and you're seeing it roughly half of that in the usual care. And these groups were pretty well matched, actually, when it came to what they looked like at baseline. And that's if you look at systolic blood pressures. And again, you see doubling of reductions in the pharmacist intervention group for diastolic blood pressure compared to the usual care group. And what I find, again, most fascinating is these are maintained 6 months post-intervention. And interestingly, I find it fascinating that all groups improved at 6 months post-intervention, not just the pharmacist group, but all. And again, remember, people don't practice in isolation. These groups, these pharmacists were practicing, but there were other pharmacists in the group not on this project that we're working with patients that were in usual care. So there are some confounding factors with usual care, and they got some pretty good results as well. I'd like to bring it a little closer to home. I'd like to share some of the work of Juliana Burton's team at UC Davis with Tim Cutler, where they looked both in 2006 at a blood pressure project and again in 2011. And these were all pharmacists managed patients in a primary care clinic, family practice clinic. And in 2006 on their project, they showed 72.7% of the pharmacists' patients achieved their blood pressure goals versus 23.3% in the usual care group. And if you look in 2011, this was confirmed again. And if you look at the results, you'll see that both in systolic and diastolic blood pressures, the pharmacist group, which is the green group after the pharmacist began intervening, showed a significant decrease in systolic and diastolic blood pressure and getting people to goal. So again, bringing it a bit closer to home in our own neighborhood, I think it's really important to share the successes that we've had here, and I really hope that this group continues these meetings at least annually with the pharmacists getting up and sharing what they have going on. So if we look at pharmacists on care teams, you can go back to the 1960s and see pharmacists practicing in the Indian Health Service. Very quickly after that, the VA began incorporating the model of the pharmacist on the care team. I spent my first 8 years at the VA here in Sacramento developing pharmacist co-managed clinics. Kaiser, of course, is what we all hold up as the medical group to aspire to when it comes to both achieving goals and integrating team-based care. Group health, again, a model very similar to Kaiser. We also know that the pharmacist's role in hospital settings has been very established and well reported. But the majority of physicians don't practice in these settings, and we know that that's moving in the direction to be in more of a group practice setting, but today they don't. Many physicians are independent practitioners and don't have access to a pharmacist on their care team directly in their practices. We also know that we have a largely undefined community setting of practice for pharmacists, and the use of the team-based concept between community-based practitioners and community-based pharmacists is also only in its infancy, and I'm hoping that we get some good ideas from Stan and Risa when they come up and talk. So I'd like to shift gears a little bit because although I still live in the area and my heart is still with care in the Sacramento area, my practice is in San Francisco, and I'm back on campus trying to look at innovative roles. And I have to tell you, I'd like to present a really innovative role of how an IPA pharmacist or pharmacy team can interact with IPA physicians who are all out there at very different settings of care and work in an ACO model. So the ACO I'm going to present to you today is, the employer group is the City and County of San Francisco, and the UC San Francisco Independent Practice Physicians are the physician group. Hill Physicians IPA is the IPA. Blue Shield is our payer partner. And we also have the UCSF School of Pharmacy and our Walgreens at UCSF on campus that are supporting the pharmacist role on this team. So I'm going to switch here to some evidence put together by Con Nguyen, who's the Director of Clinical Support at Hill Physicians, on a really important program that they put together because, again, not every group can afford a pharmacist or can support a pharmacist in the direct setting. So what they did is they became very clever and created a virtual pharmacist program. So the virtual pharmacist program is both a patient solution and a provider solution. So for the patient, it provides drug information consultations, cost-saving opportunities for patients when things are evaluated that could be done in a less expensive manner from a copay perspective for the patient, comprehensive med management and comprehensive medication reviews, medication reconciliation, especially upon discharge from the hospital, medication adherence assessments, and some disease management and lifestyle coaching. So that's what the patient is getting out of these virtual pharmacist interactions. But from the physician and providers, and I apologize, these are kind of light, what's happened is they've shared their EHR. So UCSF has shared the electronic medical record, EPIC, in our system it's called APEX, in a read-only fashion. And the read-only with messaging. So the Hill pharmacists have full read-only access to all the patients in the IPA. And what they are able to do is communicate with the physicians both through the messaging portal, and the goal someday is to truly have HIE, which we know all is the ultimate goal, right, Dr. Arevalo? Yep.
Coming real soon.
We hope. So, and I know we've had discussions about that here at the Right Care Initiative. But I think it's really important to realize that the barriers were overcome about patient privacy. That's everybody's complaint is we can't share information in the EHR because of privacy. So therefore, groups that don't have pharmacists don't have access to these types of things. So I think this is a barrier breaker, and I think it's really important to realize that what's happening with this is those pharmacists are able to do not just medication reconciliation, but medication optimization. They're able to get in there and make changes, adjust doses, discontinue meds, start medications, come up with generic recommendations, and start looking at clinical measures for both HEDIS, pay for performance, and look at gaps in care. So if you look at the results of the program, you can see the sorts of intervention types the virtual pharmacist has. Basically, again, lifestyle and pharmacy counseling. Gaps in care is the largest area where they find that they're having an impact. Prescription drug monitoring and changes in the prescription are the types of interventions that are most common. If you look at the specific type of pharmacy interventions, you'll see that the largest intervention is just drug information to the patient and the provider. Second is a change, 25 or 26% of patients need a change in therapy. And then you look at basically medications that are on hold or discontinued, drug interactions, cost savings, and the need for laboratories. So when we look at this, you can also see this was all done in conjunction with an increase in the generic prescribing rate. So if you look at the UCSF pilot, they're way up here at 86% for generic utilization. San Francisco in general is down at about 82%. And if you look at the network, they're still below, sitting at around 84.5%. So these are the types of results you can get when you do these types of things, and more patients are being impacted because of the virtual pharmacist program. I'm going to stop there and turn it over to our other ACO gurus, Blue Shield, who are definitely part of this project, working in conjunction, Autumn Cronin in the San Francisco area, with Con and her group at Hill and with us at UCSF. So with that, I'm going to turn it over to Nancy, who is with Blue Shield, and she's going to talk about the efforts of the pharmacist from Blue Shield and the payer's perspective.
Well, perhaps you can describe how the virtual pharmacist functions, just in terms of on a process of everyday message coming from the provider, et cetera.
Yeah, so what happens is patients are identified in the in the physician's queue. The pharmacists go in and look at who's on, they work with particular groups of physicians. They go in and see who's in the queue to see the physician in the next week. They then evaluate those patients that are most in need of these services, either with gaps in care, HEDIS measures, and they reach out to the member, and they do a consult with the member before the physician sees them in their office visit, so that they can actually get the information in the hands of the provider at the point of care. So it's a very interactive, proactive way. Now, what they have discovered is there are a lot of patients out there, and the screening tools to get to the right patient, to have the greatest impact, is what they're working on now. how do they identify and do severity indexing on those people that will get the biggest bang for their buck from having a pharmacist involved in the care. So there is a whole lot of interplay.
Yeah, and one of the things that we found, because we're doing this complex case management stuff, is that actually a lot of the most complicated patients are actually the most plugged in.
Most activated.
Yes,
Yeah.
absolutely. And
Yep.
so it's the group that's next in line, the next 2%, that tend to be the ones that benefit the most from that kind of thing.
Absolutely.
In this process, what percentage of patients, because I've never seen an elderly patient that didn't benefit from quitting meds, almost all. I mean, that was always when I was in training.
You're near and dear to my heart. I never saw a patient who I didn't give them a net decrease in drugs in our geriatric clinic because
Exactly.
they're always on too many medications.
So what percentage in this project?
This is not a senior population,
I
to
see.
be honest with you. This is a commercial population,
I see.
although there are retirees. This is not our classic Medicare population.
Got
This
it.
is our, it's actually quite an ill working population. It's the severity of it is much greater than our other ACO that we have in place. But it is not, it doesn't have a large senior population.
Marion, how do you overcome the sharing of the medical record information with the pharmacist? Would
So,
there be
I think that
business associated agreement or something?
Exactly, that's exactly what you have to do. And I think when you look at Hill Physicians as a partner with the physician group, right? They're the IPA group, you know, they're the administrator. Everybody's working in conjunction for care. And so how you do that, we also did the exact same agreement with our Walgreens and UCSF, is they have full access to our Epic medical record too, which is unheard of in a community setting. Again, we're working at getting them the full two-way access. Right now they have the same thing that the Hill pharmacists have, which is this full read-only and messaging capability. But I have to tell you, it's not simple, and you go through a lot of legal and compliance and patient privacy issues, but it's been done, and I will tell you, of all the places I've worked, UCSF is the most conservative when it comes to sharing patient data. So it can be done. It definitely can be done.
Thank you.
So Nancy, are you going to introduce Nancy?
I can, she did. Certainly, well, not really. I'll give you the full spiel on Nancy. Where's my bio on Nancy? I've known her for a long time, but she has a lot more accolades than I gave her right here. So she's the senior pharmacist and ACO program manager for Blue Shield of California. She attended UOP School of Pharmacy. And since joining Blue Shield, she's really contributed to a lot of their statewide pharmacy-based initiatives through the use of pharmacy and medical claims data. Prior to joining Blue Shield, Nancy was principal at IMS Government Services with responsibility for program integrity for the Medicare Part D benefit. She was also the director of clinical services at Pharmaceutical Care Network, a PBM here in Sacramento, right, Nancy? Yeah. Which she oversaw the benefit design and administration for 2 million covered lives. She previously was a regional clinical coordinator for Dignity Hospitals in Sacramento prior to transitioning to her role in managed care with Blue Shield. In addition to her present role at Blue Shield, she also participates in PQA, the Pharmacy Quality Alliance panels, tasked to develop and implement performance measures for pharmaceutical care. So Nancy, with that introduction, come on.
All right.
How do I do the slides? This advances. Okay. Well, thank you for having me today. This is great, and it all ties together. Both myself and my colleague here, Dennis, we work with a lot of the ACOs in the Blue Shield system. I not so much with Hill. Hill is really one of the more advanced groups that we deal with because they have a good staff of pharmacists, so you know they're doing a lot of creative things. So just to level set, for those of you that are not aware of our Blue Shield ACOs, we have more than 20 in California and growing, mostly commercial membership, so I'm going to be talking about commercial populations today. And they normally are composed of 3 partners, a hospital partner, a medical group or IPA partner, and of course Blue Shield. And all the partners are aligned with shared risk. And we all have both upside and downside financial risk. So we share the goal of cost containment and quality improvement. And this slide just illustrates that there's just ample literature support. Marilyn already went through it. That it's just all over the place. That pharmacists as part of the care team really add value. So I'm going to talk about 3 initiatives today, well, 2.5. One is going to be our community pharmacist NPM program. Another one is how we're using advanced practice pharmacists, and then some of our later in the year pilots that we're initiating. So this first slide is around our community pharmacist program. This was our first initiative when we started it last year in 2014, and we wanted to leverage the community pharmacists. We wanted to reach out to both, have those pharmacists reach out to both members and physicians to address drug therapy issues, adherence, duplicate therapy, and dosing. And we did this by hiring a third-party vendor to connect the dots. So every participating pharmacist in this program of ours has access to a portal which gives them a view of the patient's prescriptions no matter where they were filled. So that pharmacist can look at that patient's prescription history, and it can be filled at the pharmacy down the street or across the country. They see the whole history.
Be sure to use the microphone, okay?
Where's the microphone? This one?
You have a soft voice, so.
I'll speak up. Additionally, besides seeing all these prescriptions, we run each patient through a set of algorithms. So the pharmacist can see not only the patient's full prescription history, but they're also red flagged for all of the drug therapy, the potential drug therapy issues that the patient may have. So it's easy for the pharmacist to go in, see the patient's history, and see those flags that we've already pre-identified so that they can act upon them. The portal also provides a place for documentation, so it is somewhat of an electronic medical record with prescription claims, as a place for the pharmacist to add notes and track what they're doing and who they talk to, the patient or the physician. And also importantly, it provides a way for the patient, the pharmacist to get paid for that intervention. So it's our billing mechanism as well. Okay, this is what I share with the groups on a regular basis, and these are some of the things we're finding with what these community pharmacists are doing. Things like correcting suboptimal drug therapy seems to be a lot of what they're finding, as well as preventing an unnecessary prescription. And so what did we learn from this 2014 initiative? We've put this program in place over, I think 6 or 7 ACOs in 2014. Well, first we found that we kicked off this service to the medical group or IPA leadership really well, but we did not do such a good job of communicating with the frontline physicians. So this program was happening, but we really didn't take the time to really work with them and go, hey, the pharmacist is going to be contacting you, and they're doing all these things, and we're paying them for it. And so we needed to do a better job of that. So In 2015, we're really going to work on getting the word out. We've created some flyers, we will meet with the physicians, we've even put together some email templates for the medical group to use so they can do some broadcasts and bring it up in their quarterly meetings, and let the frontline physicians know, hey, the pharmacist is going to be contacting you, and this is what the fax looks like, or they may be calling you over the phone. But, so to make them aware that this is a value-added service, and they may find some things that they don't know about, and they should be responding to it. The number one problem with this program in 2014 was lack of physician response. So we had the pharmacists providing these faxes or making phone calls, but since they weren't really aware of the program, the number one problem was a non-response. So that's something we really are going to work on. And Dennis and I working, that's a great place for us to leverage our community, our relationship with these medical groups, is that we can try and work on that communication.
What is the name of the software that you're using to document it?
Outcomes MT.
And is there a way to communicate through that instead of through phone calls and faxes?
No, well, it can generate the fax. So the pharmacist, depending on how their practice workflow goes, they can use that program to generate the fax, but it's not, it's not to the point where you can like interact with the EMR the physician has, something like that.
Okay.
Our other aha moment was that we were having the pharmacists call patients, and we found out this is a commercial population. They're not home during the day. So we thought, well, that's not working so well. So we've retooled this program to think about what can the pharmacists do Monday through Friday during regular business hours. And our focus now is a little different. We are asking the pharmacists to do two things. And again, we're putting those algorithms on these patients, so we're highlighting the areas where we can quickly intervene. One of them, we're going to have the reaching out to the physicians around evidence-based gaps in care. So if they find diabetics, for example, not on a statin, that might be something they're going to reach out and talk to the physician about. The other thing is we really analyzed the drug classes out there. And there's some drug classes with really, really good generics. They're just kind of no-brainers. We're going to be we want the pharmacists to be reaching out to the physicians and helping them get those patients on generics, because it's going to cost, a lot of times it's a huge co-savings savings, and it'll help with the claims. So those are our true learnings on that. Okay, this is our second initiative. Advanced practice pharmacists. And what do advanced practice pharmacists provide? They can, at the top of their license, provide collaborative drug therapy management in collaboration with the physician. He's the head, the main guy, and the rest of the care team members. And why do we need advanced practice pharmacists? I mean, Marilyn's already spoken to it. 66% of admissions are for drug misadventures. And literature shows that these advanced practice services can really do a lot of things. They can reduce, and this is a big thing for Blue Shield, they can reduce unnecessary hospital admissions, ER utilization, they can minimize adverse drug reactions, reduce medical and drug costs, and just improve quality of care and get those patients access to a clinician. So what can we do to help them? Well, we looked at the gaps, and this really is a lot of the